From the general internist perspective, or even general cardiologist, at what point should we be referring patients for ablation?
Historically, when I was on the first guideline writing committee, a lot of my friends in the field were really upset with me because we positioned ablation as second line therapy. But go back to 2000, okay? I'm sorry. The data were not strong enough to argue that it should be first line treatment. But as more and more data became available, it became obvious that it was a very reasonable first line treatment. Now, fast forward to several studies published in the last couple of years that have been consistent that attacking things early to maintain sinus, regardless of the method you do, is a good long-term goal for the patient. They do better. They look at multiple endpoints, death and stroke and heart failure, and certainly quality of life indices in almost every study. Now, how do you keep them in sinus? Now, for the faint of heart, you might want to keep them on an antiarrhythmic drug. I have no problem with that. I would just be delighted you kept them in sinus. You're going to make me a very happy person, okay? But for the not so fainted heart, let's talk about an ablation. The question you ask is important. When do you send the patient for an ablation? So let me just give you a couple scenarios. Let's take a person who is on flecainide 100 milligrams twice a day. They're in their 50s. They're tolerating it well. They've not had a recurrence in 2 years. I think they should know they have a non-drug option. That's not the person I'd say, oh my God, you have to see an EP tomorrow. Now, if the person says, hey, I'd love to be without drugs, then I think you should send them to the EP. But what about the person who you've tried flecainide, you've tried sotalol, dofetilide, you don't really want to use amio, and they keep having recurrences. They wind up going to the ER 2-3 times a year to get cardioverted. I mean, that person deserves a shot at an ablation. It's all about quality of life, right? So study after study after study has shown that ablation to keep someone in sinus versus drugs wins big time, 20-30%. So to allay the anxiety of a patient, knowing that they have a much better chance of remaining in sinus rhythm, that's a big deal. So I would say the decision to do an ablation is really not something you should worry about because there's so many factors you have to take into account to counsel them. But I think sending them to somebody to discuss that should be early on, not late. But again, not if a person's having 2 episodes a year that last for 2 hours. No, I wouldn't even treat that person, frankly. Okay, I have people who get sent to me like that, and I say, what are you worried about? So there are people that you should just leave alone. They may have a stroke which you have to take care of, but if their burden of AFib is so low, I wouldn't give them anything until it got worse. So I think you have to make these clinical judgments. But I would say think about ablation earlier. I know it's a black box for you guys, but the studies support it. You may think I give ablation to everyone who comes to me that needs sinus rhythm. I don't. The patients who are well controlled on a drug and having very few symptoms, after I explain ablations, if they're anxious, I tell them, forget it. We can always do the ablation. You're fine. You're in sinus. We'll rediscuss it next year. So I think that discussion should be part of your discussion because you're the first line that patients come to. I understand that you don't have to go into all the details, but the way I would discuss it if I were internist, I would say, look, there are 2 ways. One's a drug and the other is this technique. They're both reasonable. If you think you might like to hear more about the technique, you can send them either to a patient site like the stopafib.org, or you can send them to an EP for a consult. I think the most important thing is everybody needs a discussion, risks and benefits, long-term success. The fact is there are 1-2% major complications and you have to walk through them. And a total success of one procedure is usually around the 70% mark. And the patients may say after that point, that's okay, let's give it a shot. And that's fair. But I wouldn't send anyone to an electrophysiologist who it's always, you got to be ablated. So what I try to do is make a decision regarding ablation. Is this person really going to be helped by it? So for example, there's a paper just published this week in the New England Journal on really striking results. They took patients who were sent for either LVADs or transplant workups, and they did general medical versus ablation. And it turns out they had to stop the study early. And the lines really separate. There's a dramatic difference. And that's just yet one more article saying that if you have heart failure, sinus rhythm works. Over time, all the studies have now shown if you have decreased heart function, that you will do better in sinus. And ablation is the easiest way to keep you in sinus. So if somebody is in those situations, yes, I'm going to push them more towards an ablation because the data are out there suggesting they'll benefit a lot. If somebody has very infrequent, not symptomatic episodes of AFib, I'm not doing anything. I'm not going to offer them anything other than, reassurance. And if they need anticoagulants, we can deal with the anticoagulants. For that large group in between where I think sinus rhythm is a better approach, unless they have just reasons that I think they'd be dangerous undergoing anesthesia. Let's say they have severe COPD. I will generally not send that patient for an ablation. But there are not too many others unless I really think they won't stay in sinus rhythm. And then I'm pretty much relegating them to a rate control philosophy. So it's truly a case by case basis. The vast majority of patients are candidates for ablation.